Welcome everybody to the first of the COVID-19 webinar series from Virtual Veterinary Specialists. Our speaker today is Clare Knottenbelt. I'm sure Clare is well known to many of you already. She is an RCVS recognised specialist in small animal medicine and an oncology consultant for VVS.
Hello, my name's Clare Knottenbelt, and today I'm going to be talking to you about whether cancer is truly an emergency, particularly in the context of veterinary care in the face of COVID-19. What I'm going to do is have a look at a little bit of introduction and background, look at the prevalence of cancer and what the current guidelines are telling us. Then we're going to have a look at what constitutes an emergency in general terms and also some genuine oncology emergencies. We'll also have a look at the impact of delay, both on the patient and the client, and then have a look at some common cancers that you might be seeing and get some recommendations about what you can and can't really do in the face of the current situation that we find ourselves in. So this is more of thinking of not necessarily gold standard treatment, but how can we compromise and still do something for our patients? So a little bit of background to this. I think it's really important that we understand the prevalence of cancer in our pets. In the UK, we have just over 1 million dogs, and of these, 1 in 3 will go on to develop cancer, according to a study by Pang and Argyll. And 9% of the patients we have will be diagnosed with cancer each year. So that's actually quite a frightening statistic when you think almost 1 in 10 of the dogs we have will be diagnosed with cancer. And according to an American study, almost 50% will die of cancer, particularly if they're over 10 years old. And I think we all know that purebreds are at higher risk. I've put a photograph of a retriever here because certainly retrievers do seem very prone to developing cancer. And in terms of the cats that we see, there are 1.5 million cats in the UK, and almost 20% of these will be diagnosed with cancer each year, and that's a pretty high amount. That's double the amount of dogs, which when I read this, I was really quite surprised about. And 32% of cats older than 10 years old will die of cancer. So that's a third of those patients. And this was also found in a study in America from the Veterinary Cancer Society, where 32% of cats of all ages will go on to die of cancer. So we can see cancer is a big part of veterinary care. And I suspect that many times we aren't always making the diagnosis and realising that these pets are dying of cancer. So just to clarify, are owners actually allowed to travel to the vet? So what the guidance is, and there's very clear guidance for dogs. It's quite interesting because there's guidance for dogs and dog owners, which really relates, I think, to pets in general. And then there's guidance for cats. So we'll have a look at those. The first one is if you're self-isolating. So remember, these are people who either have coronavirus or a member of their household has coronavirus, or they're choosing to self-isolate because they're in a vulnerable category, or they've been advised by the government to self-isolate. So your over 70s didn't get letters to say they needed to isolate necessarily, whereas if you've got asthma, diabetes, or some other concurrent condition, you'd be told you should self-isolate. So for this category, all non-essential trips to the vet should be avoided. So yes, your routine booster vaccination should be avoided. But if your pet needs urgent treatment, you must phone the vet to arrange the best approach to meet your pet's needs. So they're putting it back to you guys, unfortunately, to say whether you should see the pet or not. And that's what we're going to cover today. We're going to look at whether you should see the pet if it has a potential cancerous problem. The second category is the social distancing, and that's pretty much what we're all having to do right now. And again, all non-essential trips to vets should be avoided. However, if your pet needs urgent treatment, you may take them, but must remember to wash your hands and remain 2 meters away from anyone outside your household. And you must call the vet before going to see them. So it's very clear that they do need to let us know that they're coming, and we need to put things in place. And certainly with the vets that I deal with regularly, most people are having their clients wait in the car outside and then hand the pet in to the practice for care and for any physical examination. So doing an online consultation first, or a telephone conversation, and then taking the patient in to examine and administer any treatment. But obviously different practices are having different policies on this, and the key thing is that you are making sure that your vets, your nurses and the owners are all safe by applying these basic sensible rules. For cats, it's quite interesting because the only comment they make on cats is you should wash your hands before and after any contact with your cat, which is quite a bizarre thing to put in. I understand obviously it's for the fomite transmission, but obviously if your cat is an indoor cat within your own household, then the reality is you're already in contact with your own household, and so the cat will only be infected by your own household. So I think the key for me here is probably thinking that if your cat goes outside, it could be going into other households and therefore its potential risk. So you have to consider that this is really perhaps more for cats that are going out and therefore potentially acting as a fomite and bringing it in. But yeah, I'm not going to comment on whether I think this is a great idea or not. I think the reality is this is what's up there, and that's all I can share with you right now. And it may well change as the situation changes over the next days to week. So now we're going to look at, is cancer an emergency? And, I think this is a really important point because cancer is a highly emotive word. And for many of us, the word cancer kind of almost equates to a terminal event. We know that we have friends, relatives, people we know through other friends that have had cancer. And we always talk about cancer as being a battle. It's always they've battled cancer, they've fought cancer, they've beaten cancer. It's very much about a battle, which is going to be a struggle to win. So for that reason, as soon as cancer is considered a possibility by an owner, they will become extremely fearful. And the other factor that we need to remember as vets is how heavy the emotional burden of having a pet with cancer can be. It really is enormous. I lost my own dog to cancer 9 years ago and lived with him knowing that he had this cancerous growth in his neck. He had a thyroid carcinoma. Knowing that he had that for 6 months and not really appreciating the weight of the burden that I was carrying over that period until the time came to put him to sleep. And at that point, it literally felt like somebody had been piling bricks into a rucksack on my back for 6 months. And I hadn't noticed because each brick was only a small increase in weight. But when he was put to sleep, the weight was lifted off me, and it was a tremendous emotional burden. And I think as vets, generally, even outside of the coronavirus issue, we don't always realise that. It's very easy to keep pressing on, and the owners are actually, they're done. They're so exhausted. They cannot continue. And they're kind of looking for permission from us sometimes to say it's okay to stop. So just be aware of that. That happens all the time, not just in the coronavirus outbreak. But the COVID-19 situation means that people are already very frightened. Okay, so they're already heightened fear because of the fear of losing loved ones, dying themselves. What's the situation going to be? How's the economy going to be? Am I still going to have a job? There's a lot of things to be scared about right now. And that means they already have a very high emotional burden of fear. And if we're going to add on to that by this whole idea of their pet may have cancer, or, they don't know sometimes if it's got cancer or it hasn't got cancer, they may have a heightened fear of the situation. This also means that decision making is really, really hard for both pet owners and for us as veterinary professionals, and that's your nurses, your vets. For all of us, decision making is really difficult. We're having to make a lot of tough decisions now, and they might sound trivial, but they are tough decisions on a daily basis. And the more decisions you have to make and the more fear you have, the harder it becomes to make good decisions. So you may find owners can't make up their minds. They don't know what to do with their pet in a particular situation. So be ready for that. You may struggle to make a decision. You may struggle to know the right outcome. And that's where you need to reach out. If you need help to make that decision, that's what people like me and the other specialists at VVS are there for. We're there to help you make the decision. Okay, so reach out to your colleagues, reach out to your friends. So now we're going to have a look at the obvious oncological emergencies, okay? And the funny thing about this list is that actually many of them are pretty poor prognostic indicators, okay? So the obvious oncological emergency, we almost have to ask ourselves, should we be dealing with that? Or rather, we do have to deal with it, but should we be doing everything to make the diagnosis for these patients and then leaving the other ones that actually have quite a good outcome if we do something with it to not get treatment? So, looking down this list, we can see there's a whole range here. Of things. We have the obvious, the hemoabdomen, usually presents collapsed. The pleural or pericardial infusion that's down to a neoplastic problem is going to have a poorer prognosis. There's no doubt about it. These animals are not going to live for a long time. Urinary obstruction, obviously you can get reasonable survivals with bladder tumours and so forth. So, that is and some animals will be presenting with stones as a urinary obstruction, which are perfectly fixable. We've got the GI obstruction, which in my opinion is pretty bad sign. You're going to have to consider, are you able to do surgery and so forth. Hypocalcemia, again, it usually often has an underlying neoplastic problem. A lymphoma or an anal sac tumour are the most common reasons for hypocalcemia out there, and obviously neither of them carry an awesome prognosis when they've got high calcium. You're going to have your chemotherapy associated neutropenics, and they should be perfectly fixable, so they are ones that we should be able to do something about. Your hyperglycemias, I've only seen these very, very rarely. Obviously they could stem from an insulinoma. They can also occur with very large liver tumours. So those ones, probably not a great prognosis, not something we're going to be able to necessarily fix easily. Degranulation of neoplastic mast cells. I must admit, I've only seen one case that ever did this, despite seeing hundreds and hundreds of mast cell tumours, so it's pretty rare. Hyperviscosity syndrome, that occurs in your multiple myelomas, and again, pretty rare. I've seen a number of myelomas over the years, and very rarely do they present with hyperviscosity syndrome. DICs, well, I'm afraid I was brought up in the era of DIC standing for death is coming. And I know that now we can actually do a lot with DICs, but I really think in this current situation, we have to really think about, is DIC the right thing to be treating? Because it is a pretty bad disease, and yes, you can get animals to recover from it, but if the underlying reason for DIC is neoplastic, then I really feel that this is not the appropriate time to be having a massive fight to keep these patients alive. You can also get tumour lysis syndrome. So this is where you've treated a tumour very aggressively and you're getting a lot of release of cytokines and other chemicals within the body that makes the animals quite ill. Again, do you know what? I don't think I've ever seen a case go into tumour lysis syndrome. It is theoretically possible with a very extensive lymphoma where you've got a lot of disease and you treat it very aggressively. But mostly now, I'll try and be a little bit cautious in the patients where I think they might have this and just kind of stagger things a little bit, so we're not getting this massive acute tumour lysis syndrome. So some of these are a little bit academic and may not be that significant. And I've highlighted the ones that indicate a poor prognosis or that will be complex to manage. So when we're thinking about the situation that we currently find ourselves in with COVID-19, we need to look at some general considerations. What are you most concerned about? Are you concerned about the risk from getting infected yourself, from colleagues or clients? Are you concerned about the risk of you infecting colleagues or clients? Or are you most concerned about your lack of staff? Okay, have you furloughed a ton of staff? Have a lot of staff had to go off because they've got childcare commitments with schools closed? Have you got a lot of people who are off sick? Can you offer any sort of surgery at all? Okay. On many of the Facebook forums, people are discussing about whether it's right to use PPE for surgeries. Can you do surgeries within the practice environment? Obviously, in a surgical suite, you're going to have someone monitoring the anaesthetic and assisting you. So you're going to have more close time together. It's going to be a longer period of time together. So can you offer that or can you not? And I think it's important to be very clear what you can and can't do right at the start. You need to ask yourself if you should prioritise emergencies with a poor outlook, and we've discussed some of those ones there in terms of genuine oncological emergencies, or urgent cases with a better outlook. Now, for me, I would always feel that you should prioritise an urgent case with a better outlook than a emergency case with a poor outlook, but obviously the emergency case will have to be seen, even if the next step is to call it a day for them. Is there any way you can stay safe or enhance the safety of your team by working separately? So a lot of the practices I work with are doing sort of rotation systems to try and make sure that everybody is taking a turn to be in and working, but then they're getting some time away as well, so that if they are incubating anything, you've got time to kind of see that it's come. And please seek advice. We're here to help you. That's our job. That's what we do all day. And we are lucky that our work has been done online. My job involves mostly online work. I do still do some face-to-face appointments, but it means that we're already experienced in supporting you in this virtual way. And so we're here to help you. And please, 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 reach out. That's what we're here for. Okay, you're not on your own. You don't have to make these difficult decisions when your decision making power is perhaps a little bit impaired. We can kind of share our power. We've all got impaired decision making right now, but we can share our power and hopefully come to a sensible decision that everyone's comfortable with. So in the next few slides, we're going to have a look at some cases, some common presenting cancerous problems, and we're going to look at the alternatives to standard care in the current COVID crisis. So I really, really want you to be aware, this is not me saying in a perfect world, this is what we would do. This is not a perfect world we're in, and I'm going to try and help you look at how to deliver the best treatment that you can within the context that we are currently working in. So first, we're going to have a general look at the impact of delay, which applies across a range of different tumours. And I came across this fantastic quote by Maya Angelou in a completely different context, nothing to do with my veterinary work, and it really resonated with me. It really made me think, yeah, this is what we have to remember as vets. People will forget what you said, people will forget what you did, but people will never forget how you made them feel. And I'm sure if you think back to either a consultation that you've done or that kind of surprising fact, when I was a new graduate, the owners loved the senior partner. They loved him so much, and sometimes I would look at what perhaps they had done and think, that's not the way we would do it now. That's not the way I've been trained to do it. But they would love him, and that was because of the way he made those clients feel. Okay. We know our clients will forget what we say. They do that all the time, don't they? They will even forget, you ask them a week later, did you get an injection of anti-sickness? Or I can't remember. So they genuinely do forget what we did. But they will never forget how you make them feel. And I think it's really important that we make them feel that they are cared for and nurtured, and that their love for their pet is the same as our love for their pet. So it's really important that we do that, and even more so at this time of the COVID crisis, because this is the time when we know what we're going to have to say and what we're going to have to do perhaps isn't perfect. It's not what people necessarily want to hear, and it's not necessarily what we would ideally do. So when we think about the impact of delay, in my honest opinion, honesty is always the best policy. Okay, don't try and pretend that what you're offering them is what you would normally offer them. explain every option, explain the prognosis, because it's certainly in my experience, a lot of times when I'm having consultations with clients, they've come to me, they've been referred, they want to spend the money on referral, but when I go through all of the options, they don't want to do it. They just wanted to know that they had explored all the options. And for many people, chemotherapy isn't an option. They don't want to do it. They may have kids in the household and they don't want to be in that restricted situation where the kids can't be sort of literally wrestling with the dog and letting the dog lick their faces and all that sort of thing. So they may not want to do gold standard treatment anyway. Okay, and if they reach that decision of their own volition, then you've had a win, okay? Because now you don't have to do it, which is what you didn't want to do in the first place, but they don't want it, okay? So always start with every option and then explain the situation that we currently find ourselves in. You need to explain why the situation we're in means some things are not possible, and you need to explain that properly. Now, you need to take time to do this. It can all be done online. Okay, so it can be done virtually. These conversations, I do a lot of consults direct with clients online, and you can explain stuff to people really, really well. You have their full attention. They can have multiple people on the call, which can be really helpful. If Granny had a really big part in the dog's life, she may want to be involved. She may want to have a discussion about that, and it means you can really explain everything to them, and we really need to do that. And this is difficult because we all don't have a lot of time, we've got short staff, but it's really, really important. You also need to give a time frame within which they remain possible. So for example, if you decided to go on steroids alone for a lymphoma patient, you really have a week in which to decide if you want to do chemotherapy or not. After that, you are running the risk of multi-drug resistance. So you have that time frame. If you've got the option of doing follow-up chemotherapy after a surgery, for example, you need to look at the time frame within which it would still be reasonable to do that, because we don't know how long we're going to be in lockdown for. We don't know whether the situation is going to change. So it's really important they know within the sort of time frame that things might change and what that change might look like. Because if you don't tell them that this might be possible in, say, 6 weeks, if the lockdown's closed, then they're just not going to do that. They're going to eliminate that completely. And they then might find out later that there was an option that you didn't raise with them. And I think that's something I've learned as an oncologist, is even if someone comes into you and says, I don't want to do radiotherapy, I will still tell them that I'm going to tell them about radiotherapy, because I don't want them to then go away, talk to somebody, or look on good old Dr. Google and come up with well, she never told me about that. Okay, so I always tell them I'm going to tell them about everything, even though things aren't always possible or aren't always practical and aren't always affordable. And I do that anyway, even outside of COVID. So I think it's really good practice to do that. And then you even in the COVID situation, you're just adding an extra layer, which is, well, we're stuck in this situation. Here's what we can and can't do. So there is another impact of delay. There's not just the impact of delay on the client and the client's kind of perception of the treatment. There is also going to be an impact of delay on the pet. And it's really important that we share that with the client. It might be difficult for them to hear that because of COVID they can't get the treatment, which means that they may have more problems. They may find that the mass becomes difficult or impossible to remove, that there's a risk of spread. And I've got a picture of my dog here. This is Huntley, poor Huntley. He's a vet's dog, so he has a hard wee life, or he had a hard wee life. This is the dog that developed a thyroid carcinoma, who I lost almost 9 years ago now. And the funny thing about Huntley is I first noticed his tumour when it was probably the size of a wee walnut. And being a vet and being someone who's sort of a bit of an ostrich when it comes to my own pets, I buried my head in my sand. I convinced myself that this was just a thyroiditis because he was hypothyroid and Addisonian. And so I didn't ignore it. I also had a young family. I was busy. I was working. And so time passed, and a couple of months later, he didn't have a small mobile walnut-sized mass anymore. He had a very fixed, attached, massive thyroid carcinoma. And at that point, really, there wasn't very much we could do. Surgical treatment would not have been possible. He would have needed radiation and blah, blah, blah. Anyway, the point being that I didn't deal with it when it was walnut sized, and I should have. There's no doubt in my mind now that I should have, because that would have been perfectly resectable and potentially curative. So that has made me more sensitive to progressive disease. It has made me more sensitive to owners' perception of when we go, oh yeah, just monitor it and see what happens, and then it goes completely crazy. You're pretty pissed off, and understandably so. So, he subsequently died with that condition. We made various decisions not to treat him with lots and lots of stuff, and he struggled to breathe latterly. So there was some at least discomfort associated progression, but where the tumour is and how it presents can make a difference to the signs you see. The picture on the top there is a reconstruct from a CT of a cat that I saw quite recently, which had presented with a cough, and it had been chronically coughing, and this is why, because it had a massive lung tumour. Now, the owners probably wouldn't have put that cat through surgery even if the tumour was small, because the cat, it was difficult to handle, didn't like being hospitalised. So already there were reasons, and both of these cases, there's reasons why we're not doing something which are outside of our immediate clinical judgment. So this is owners' perception about things. So sometimes owners make the decision to do nothing, and there will be disease progression associated with that. And here in COVID, we may have to make the decision to do nothing, and there may be disease progression associated with that. So I think if we're honest with people that this is what could happen, I think they'll cope with it better, and it will make us have a better relationship with them. It's about that honesty, it's about that trust, it's about that loyalty. If they see that we're upset that we can't do any more for their pet, they will trust us, okay? If we appear to just not care and say, well, we can't just do that. And it's really tough, because when you're under a lot of pressure, it's much easier to snap than it is to be compassionate. So just take that moment to remember that by telling them that the disease is going to progress is not guilting them, it's just honesty, and that's where we need to be at the moment. So moving on to specific cases, and the obvious emergency, top of my list for the genuine oncological emergency was the hemo-abdomen. And obviously when we think hemo-abdomen, as an oncologist, I immediately think splenic Haemangiosarcoma in the dog as the main thing. So current evidence suggests that about 50% of splenic masses are Haemangiosarcomas. That will obviously be a little bit higher in your German Shepherd dogs, where they are predisposed to Haemangiosarcoma. But we also have to bear in mind that 50% of splenic hematomas will have a hemoabdomen. So that's a benign condition. So this is a difficult call. Most people would see this immediately as a genuine emergency. You've got a collapsed dog, it's bleeding into its abdomen, you're going to have to open up and deal with this. Now, there are some concerns out there. Some vets are concerned about whether it's right to use PPE, which is in short supply, for surgeries. I think that's a practice decision that you've got to make. And, we touched on this earlier. If you're not doing any surgeries, you need to decide if you can stay open genuinely as an emergency centre, because you are going to have to do something from time to time, and you're going to have to decide whether, there are cases to sacrifice. And this is a decision that we are as a society having to make within the NHS. There's no doubt decisions are being made about who to ventilate, who not to ventilate. And we are going to have to make those harsh decisions as well, potentially. But that is an individual decision for you to make. I'm going to assume that you are prepared to do surgery, and you are prepared to use some protective clothing so that you can do surgery. And we were talking about the normal surgical protection here. You may need additional if you're concerned about your staff in terms of face masks and so forth. But that is beyond the context of here. Anyway, 80% of hemangiosarcomas will have overt mets. So it's definitely worth x-raying. X-ray the chest before you do the surgery. Just check. Okay, just check that there isn't anything else going on. It can be difficult, obviously, to scan the abdomen when it's full of blood, so you may find it a bit struggling to look for mets in the liver, for example. But if you see mets in the liver when you open it up, then you see mets in the liver. So I would definitely say do a chest x-ray first. Yes, it might prolong your anaesthetic a little bit, but if it's got raging mets, then you may want to ask the owner if they really wish to proceed. If you just do surgery in your splenic tumours, you're only going to get between 3 and 12 weeks for splenic haemangiosarcoma, so survival times are pretty poor. But interestingly, there's been a recent small-scale study looking at turkey tail mushroom extract. You can buy this online. It's capsules that you give at home, the owner gives. It doesn't require routine monitoring. There's been no associated problems with bloods with this using this particular chemical. And amazingly, it seems to give similar survivals to the doxorubicin post-operative treatment that we used to recommend. So for me, that's a no-brainer. I'll certainly, even before COVID, talk to people about using turkey tail as an alternative to doxorubicin, or in some cases I have used it in conjunction. I don't know how effective that is yet, because it's still early days with that, but turkey tail, way to go, easy. Owner can give it at home, owner can buy it online. So a straightforward option for them, which should give you somewhere in the region of about 6 months survival time, so similar to the doxorubicin. So now we're going to move on to what one might perceive as the other extreme, the lump. Okay, so the lump we tend to consider, oh dear, a lump, that's not an emergency, that's not urgent. But the challenge here is that some lumps may be urgent. They may be a genuine emergency where they're immediately compromising the welfare and health of the patient. So I've given you a whole bunch of photographs here, which hopefully cover the different kind of ideas. So the ulcerated masses over on the left-hand side, the little schnauzer there, with an ulcerated mass on its hind leg, and this was actually a husky. You can't really tell from that picture, but it was a husky with a severely ulcerated tumour. Now, both of these would be perceived as being an emergency under the guidelines. They are bleeding, they are potentially causing the animal some discomfort and concern. So the challenge with these ones is what can actually be done for them. The lump on the schnauzer leg is pretty massive, and actually was a mast cell tumour, so margins at that location are going to be extremely challenging. And the ulcerated husky one, that is a recurrence of a high-grade soft tissue sarcoma. So I would question, in that situation where you've got the recurrence of the high-grade soft tissue sarcoma, what can actually be done, and what are you hoping to actually gain from doing it? This had two kind of masses. I think you can see in that picture two clear masses that are sort of separate now, that have burst out. And I personally now would say that one is probably a time to call it a day. It's a recurrence. You've already attempted it. It's not going to have a great prognosis. It's going to be a really challenging surgical site. The one higher up, yes, it's a mast cell tumour. Let's find out why it's been left so long. Has there been a reason, or has it just suddenly erupted? Okay, now looking at that, you can't tell it's a mast cell tumour, and the only way you're going to be able to tell that is to FNA it. Okay, and I think in that situation these ones are easy no-brainers. The one against the eye is a little bit more challenging because it's a really subtle little lump, and you might say, okay, that doesn't really warrant an urgent appointment at this point in time, but it is actually a mast cell tumour, and you wouldn't be kind of able to tell just by looking at it. The only way you can tell is if you can get an FNA of that, and that's not going to be that easy because of its location, so you are going to have to consider the implications of having to sedate and so forth. The one at the top, the next one along from the little schnauzer, that's actually a soft tissue sarcoma, but I think if you looked at it, you'd probably go, oh yeah, it's just a little cyst. And certainly it's quite tempting to leave that one. That would not be considered an urgent particularly, but it's really sensible to have the owner continue to monitor that, maybe to take a once weekly photograph with a wee ruler up against it so that you can assess whether things are starting to change radically, because it's actually in a quite good location. It's across the chest of the dog, so there's a reasonable amount of spare skin, so surgical removal should be pretty easy at this point. Obviously it won't be if things go crazy, so the little tiny lumps we just need to be sensible about. Probably don't need to see them straight away, but we do need to bear in mind that we could be in lockdown for many months, and if we're in lockdown for many months, these sort of things can turn nasty. The foot below it, that is a big lump in a really, really awkward location, and this one was flaring up and down, which automatically makes you worried that it's a mast cell tumour, which it was. So that one is going to start to impair the capacity of the dog to walk probably fairly quickly. So one might argue that that has a more urgent tendency rather than a less urgent tendency. The one just immediately along from that in the golden retriever, this one really looked and felt like a fatty lump, but is unfortunately a mast cell tumour. And this is one of the big challenges. You can look at a lump and, see it on a photograph or see it on a video, get the owner to kind of squeeze it. Is it soft? All of that. But this is still a mast cell tumour. And this one actually turned out to be quite a high grade tumour. So we don't know what we're dealing with, and it's really important that we are clear that we don't know. Okay, doing an FNA will obviously tell you what you're dealing with, and is can be done literally. I mean, most of the FNAs I've done, I've barely needed someone to hold the dog. It depends on the dog, but most times I don't need them to hold the dog. Cats, slightly different. They tend to wander off. Dogs usually want to be your friends, so there's ways of aspirating with only you present, and obviously that's going to reduce the risk to people from having to handle the dog. The one above that, the leg, that is another soft tissue sarcoma. It's in a really awkward location, and that it's probably going to require either very complex surgery followed by something else or an amputation. And sometimes when you say that to people, saying, well, to remove this mass, we're probably going to need to amputate your dog's leg, they don't want to do that. So they're delaying, which makes life a little bit easier. And again, this is the other leg. In fact, both legs, I should have said the golden leg there, but both legs are soft tissue sarcomas. Okay, so the reality is we don't know by looking at these things necessarily what they are. And the last one in the top right-hand corner, the little Cavalier King Charles Spaniel, I just put this one in here because this is actually a cutaneous lymphoma patient, and the owner reported a sort of lump in the lip, basically. So this one has a more systemic issue going on than just that lump. Okay, and so it's really just being aware that just when you look at something, you can't really tell what it is. Okay, and it's up to you as a professional to decide, do I leave it or do I FNA it with relatively low risk of problems, or do I do something more radical? Do I go in and do proper surgery, and how do I balance that? And there's no right or wrong answer. Okay, again, it just comes back to the honesty is the best policy. Explain the situation, explain your dilemma, but be clear on what your solution is and what you're proposing. So you can say, look, on the one hand, we could take this off right now and it's relatively quick, easy surgery. On the other hand, we really shouldn't be doing these kind of surgeries right now. So I think we're going to leave it, but I'm going to stay in touch and I want you to send me pictures, and then we'll make a decision if that needs to change. And if the situation with the lockdown changes, we may need to change our mind. But this is what my plan is, and this is how I'm going to deal with it. And we're going to look now at the mast cell tumours and the soft tissue sarcomas, just to really give you an idea of what you can and can't do, and what you maybe should do, and the outcomes you might expect from a delay. So in mast cell tumours in dogs, prompt surgical resection may be curative, and that is the challenge for us, because if we delay too long, we're not going to be able to surgically resect it. We may run the risk of more mets, and therefore the risk that we might need to do chemotherapy. Okay, and this is where the problem comes, because the need for chemotherapy is going to depend on your ability to achieve surgical margins, the grade that you've determined on histopathology, so you're not going to be able to grade it on an FNA alone, and whether there is any evidence of local or distant metastasis. And that is something that really has to be done in the animal. That's really the only way to do it. So obviously, if a patient has had mast cell tumours before, they're more prone to them, so you've got an increased likelihood that it is a mast cell tumour in the first place. But also certain breeds are really prone, so boxers, golden retrievers, your pugs, basically a lot of the squish face, they tend to be more prone to mast cell disease. And the challenge for owners is that if you've got a high-grade tumour, you can significantly prolong survival if you're prepared to do chemotherapy. So this then raises the question, are you prepared to do chemotherapy? So it's really important that you're clear on that too. Are you prepared to do chemotherapy in the current situation, or are you looking to potentially delay? So when it comes to assessing these masses, there are certain things that should prompt concern. So if the owner reports a sudden rapid growth, or there's been fluctuations in size, so, oh yeah, it was really big yesterday and now it's gone back to where it was before, that really worries me, because that's an angry mast cell tumour, particularly if there wasn't any trauma associated with it. My own dog, my current dog, had a little subcutaneous mast cell tumour on his head. It was absolutely tiny little pimple. I stuck a needle in it. It swelled to the size of a golf ball. Yeah, it wasn't high grade, and I stuck a needle in it, okay? But if it had swelled to the size of a golf ball and then shrunk back down to nothing spontaneously without any kind of trauma, that is kind of worrying, because it suggests that the mast cells are degranulating. If there's any evidence of ulceration, then that is going to be a problem. It's going to be bothering the dog. It's going to be looking at it, hassling it. And so that may warrant you to actually examine it. And it's a difficult one, isn't it? Because there are ways we can control that discomfort for the dog. We can give them pain relief. We can put a collar on, inflatable collar, so they can't get to it. Buster collars, interesting that there has been a recent study looking at the welfare issues associated with buster collars. So we need to think about, is it compromising the welfare, but also what can we do? And also, is it a tricky location? So this this is really not good. This is a really tricky location. And so therefore prompter action may be required where you've got a really tricky location, because what you don't want is to leave this and end up with a massive, horrific problem. You can, however, consider palliative prednisolone or antihistamines if surgery is not possible, and that may bring things down a little bit, okay? But again, just be honest with the clients. I had one patient who had quite a large mast cell tumour on its bottom, and it was given steroids to bring it down. It then had surgery to remove that much smaller mass, but we didn't get the margins on it. It wasn't actually myself that did the surgery, but we didn't get margins on it, and so then we had to go in and do more surgery. And so artificially shrinking the mast cell tumour is fine in the short term, but it may not give you your longer term outcome that you actually want. So just balance that, and again, try to be honest with these clients. So when it comes to sarcomas, most cases can be managed just with surgery. So, we talked about this one before, this black dog. To get margins on that sarcoma, you're going to have to amputate the dog's leg. Now, the owner may not be up for that. That's the reality of it. So it's definitely worth discussing that. And it's also worth being aware that in high-grade tumours, 40 to 44% will develop mets. So again, it begs the question whether it's worth just doing that quick chest look at the chest and see. It doesn't take a massive amount of time, because if there is evidence of metastasis already, then it may not be worth proceeding with the surgical procedure. You can also monitor the behaviour of the mass, because sometimes with these sarcomas you get what's called low-high ones, and that's where when you've biopsied it, it comes back as a low one, but it behaves more like a high one. So they're not as straightforward as saying, oh, it's low grade, therefore it's fine, it's high grade, therefore it's terrible, because you get these weird ones that sometimes just do their own thing. They say they're low, but they don't behave like one. So the behaviour of the mass can be useful, but in all likelihood this is going to progress. And, we can see from the husky we showed you earlier that, they can progress in quite a horrific manner. Potentially they can burst out and become ulcerated and very uncomfortable for the dog, and not very nice for the owner, actually. And, we're moving into spring and into summer. There's going to be flies around. This is an absolute hotbed for fly strokes. So we have to do something, whether that is call it a day and say no, or we have to try and get this dog into some sort of state where it's not going to be plagued by flies and just have a horrific time bleeding everywhere. Okay, so really think about the overall welfare versus the likely survival times. I think this dog, I would say, would probably get 6 to 12 months at the absolute outside. And so is it worth putting it through everything that's going to have to go through? And that just needs careful management of these owners. With sarcomas in dogs, we have in the past treated with radiotherapy. That is not necessarily going to be feasible right now. I think most centres are not going to be offering routine radiotherapy to people. And in addition, you can consider chemotherapy. But again, really, that is probably something to postpone at this point in time. There's just not enough to support its use, unfortunately. You can use metronomic chemotherapy, but they will still require regular monitoring. So that means that you're not doing that 20-minute infusion with doxorubicin, but they are still going to require blood sampling. So it's weighing that up. But metronomic chemotherapy, which is a combination of cyclophosphamide tablets, which the owner gives at home, and non-steroidals, can be used to try and slow progression of these tumours. So that might be a reasonable compromise. I would usually blood test them every couple of weeks. So if that is a reasonable thing for you to achieve within your practice, then that may be the way to go with these patients. When it comes to feline injection site sarcoma, these are really challenging. You can see on this cat here, a sort of hunchback appearance. This is a pretty far gone feline injection site sarcoma. And they tend to be quite high grade. However, they can be managed with surgery if it's done early enough. But the number of patients I've seen where they've not been managed early on, they've not had appropriate surgery early on. So for me, this is a really difficult call because they tend to be non-painful, so the cat is not bothered about them at all. But if we don't do something about them when they're small, it's really going to become challenging and may actually involve resecting the top part of the dorsal spinous processes of the spine as well. So not a nice one to call on this one. I think if you suspect a feline injection site sarcoma, this is one where we should be trying to chop it out if we possibly can relatively quickly, because these ones do progress quite fast. So around 20% will develop mets. So again, just take that chest x-ray beforehand just in case, because that might get you off the hook in terms of how much surgery you're going to have to do. This is a really difficult call because these are not strictly emergencies, and they will probably not deteriorate within the next 3 weeks, but they will for sure deteriorate within the next 3 months. And you can't predict. You can't look at that cat and say it will definitely not grow that fast, because they can just suddenly go crazy. I've seen ones where they've tootled along, and then suddenly, bam, they've just gone mad, and they've suddenly grown really, really extensively. So this is a hard call. And I think, from what I would advise you to do is think carefully. If you see one of these, have a proper discussion within the people in the practice about whether you should do this now or delay, and make a group decision and keep the owner on board with that decision. Now, we know lymphoma in dogs is a really common oncological presentation, and this is a tough one for me, I must admit. I've actually already had a number of people get in touch because their vet is unable to offer treatment, or is fearful of offering treatment, or fearful of committing to treatment, and that's completely understandable. But putting myself in the context of the owner, if you've got a dog with lymphoma and you know that no treatment is going to be a 4 to 6 week survival time, that's rubbish, especially if you then go online and find out that you could expect to get 6, 12 months or even longer if you are able to do chemotherapy. So this is probably the most heartbreaking and hardest decision to make. Prednisolone alone gives you between 2 to 3 months, but it's really worth bearing in mind the side effects of prednisolone can be substantial. So you do have to talk to owners about this, even if you're only going for palliative care. And I would say this at any time, not just COVID related. Average survivals with prednisolone are 2 to 3 months. It is quite a wide range though. When you actually look at the literature out there, there are some dogs that have survived years on prednisolone alone. We don't know why. Why do some survive a matter of weeks and some survive years? I've had a dog where it just gone through CHOP and then went on palliative pred, and 2 years later it pitched up in the clinic for an eye problem, and I was like, what the hell are you doing here? You should have been dead years ago. So there are dogs that was, to be fair, it was the size of a small table. I mean, it could have been a coffee table, the size it ended up. But the great thing is some of them do awesome. Some of them do really, really awesome. But I tend to start with a 40 mg per meter squared dose, particularly in the large breed dogs. You can see this picture here. It's a wee dog called Jerry, and he had significant muscle atrophy with being on steroids for a prolonged period. And actually, this was during his CHOP steroids, so it wasn't even going to stay on for a super long time. chemotherapy, if we went for the perfect protocol, we would go for a CHOP and we'd be expecting to get 9 to 13 months. But as I touched on earlier, this is an intensive protocol. It's a visit every week for 4 weeks and then a week off, and that kind of tootles along all the way through. So this is an intensive protocol to be committing to at this time. So an easier protocol might be to look at your lomustine prednisolone option, okay, which obviously gives you less of a survival time, but might be more easy to manage. And I've put this picture up here of the spaniel. This is Ollie. He's a patient of mine who's just about to turn 8. And I first saw Ollie when I think he was about 3 years old, and he'd been diagnosed with lymphoma. It was a stage 2 lymphoma. He had some chemo. He really didn't react well to it at all. So we took him off chemo, and guess what? He's still going strong. So there are the cases out there that can do super well. And, death isn't always inevitable with lymphoma. It usually is. But the reality is there are patients out there who have made it through that 2-year period and are declared cured. But the majority of them are not. That's not going to happen. So, don't give up on your lymphoma patients. That's my one plea. Don't give up on them, because actually you can make some good progress with them. So what can we do? Okay, if we go down the prednisolone only route, at least initially, then we need to just be aware that chemo resistance is going to be likely if it's more than 7 days. So if you're going to be saying, I'm going to do 4 weeks of prednisolone only with a view to then potentially being able to start chemo, obviously it's all up in the air right now. We don't know. Is it going to be 8 weeks? Is it going to be 8 months? Who knows? God, 8 months, I'll probably kill my children before then. But if it's a few more weeks, then it might be possible to start doing other things at that point. But bear in mind, if you've gone down the pred-only route, you are going to run the risk of multi-drug resistance. Okay. With chemotherapy, as I touched on the last slide, we could consider a lomustine pred protocol. This is a tablet-only regime. You do need to do bloods every 3 weeks. It's a heme bio every 3 weeks. And in the current situation, probably my advice here would be to go cautious with the dose. Yes, not ideal because you want to induce aggressive remission, but what you don't want to do is be having any neutropenic events, because as soon as you have a neutropenic event, you're going to need to do another blood. Okay, so if it comes in at 3 weeks and it's neutropenic, you're going to have to delay, and then you're going to have to do another blood to check it's okay. So don't overcook the regime. Okay. If you want, you can add L-asparaginase in at the start. It's really super expensive, but it's a single injection. It's given subcut. Stings like hell, by the way, but it's given subcut, and that significantly improves the remission and the quality of the remission that you're likely to achieve with this protocol. So I think this protocol is a fair compromise for people, because owners can give tablets, and if we have to, we can still change to CHOP in the future if the lockdown's lifted. So we have this kind of temporary holding place, if we like. Now, I would normally do it the other way around. I'd normally go CHOP and then a rescue with a lomustine protocol, but we can swap it around. Okay, you'll find that the T-cell ones I'll always jump to lomustine in the first instance, but B-cell ones will respond to a lomustine protocol as well. So I think that's a reasonable compromise that we can achieve. The other thing I also should say is, personally, I'm not a big fan of nadir checks. I'm not a big fan of nadir checks at any time. I kind of think if the patient's ill, it will come in and it will get a blood sample taken, and then I'll see that there's a neutropenic episode. Other oncologists disagree with that. Other oncologists are very big on nadir checks. At this current juncture, I don't see any reason to do nadir checks. The reality is it's just another visit. We tend to do a nadir check around 2 weeks for lomustine, but honestly, I really don't see the point of doing that. I think it's just another visit and another blood sample, okay? And you're still going to have to redo your bloods before you give the next chemo, because even if the nadir check was okay, you're still going to double check that it's still okay just before you give it. So for me, nadir checks, I don't bother. And at this time with coronavirus, absolute good reason not to do it. So now we're going to move on to lymphoma in the cat. And it's important to remember that in cats, they often present as an alimentary form. So their symptoms are usually going to be gastrointestinal in nature, so anorexia, vomiting, diarrhea. Sometimes you'll see only weight loss, and owners won't have noticed any sort of change in fecal character. So these ones tend to present in many of the things that would probably be assessed as an emergency anyway, and then obviously the finding of lymphoma is part of that routine GI investigation. It is important to understand, therefore, that many of these will have been diagnosed on biopsy or on surgical removal of the mass. But if you do have a patient that has presented with an abdominal mass, it is actually really easy to FNA them in the cat. Now, people do get a little bit scared about this, and maybe it's because I'm so old that, it was the days where ultrasound wasn't that widely available for people. I have done blind FNAs of abdominal masses in the cat. It's important that you can actually hold the mass steady, obviously, so that you can get your needle in it. Now that we have ultrasound, obviously we can use that as well to guide us and to make sure that we're not going into the lumen. And a lot of people are scared about that principle of, oh dear, what if I go into the gut lumen? Well, the reality is when we resect a piece of bowel and we stitch it back together, yeah, we're folding the ends in so that there's some degree of reasonably quick seal, but it's not an immediate seal. Okay, so the intestine is actually tougher than we think. And, I have had a situation on one occasion where I've got gut contents rather than a nice FNA, and I've gone a bit like, oh no, what have I done? But, the risk is relatively small, particularly if you angle your needle rather than trying to aim straight to the center of the mass, if you angle your needle. And obviously the advantage of ultrasound here is you can use that to make sure that your needle is well away from the central lumen. Ultrasound will also obviously help you identify if there's potentially disease elsewhere within the intestine. So you can have a localized mass, and they tend to present sort of ileocecal colic area as a large mass, but they may well have infiltration elsewhere within the intestine. The good thing about cats is they are really tolerant of steroids, so they don't tend to get steroid side effects in the same way that dogs do. So that means they're pretty tolerant of the prednisolone only option, but they do only still get that 2 to 3 months remission time on average. And also, we just need to bear in mind that chemo resistance still occurs if we're going to use steroids for more than 7 days with a view to starting a chemo protocol. Generally, with these cats, is that they'll present in 2 different ways. You'll have the low-grade lymphomas, and these ones can be managed by the tablet-only medication of prednisolone and chlorambucil combined. But they still need blood tests, so they still need to come in and have regular checks. You usually start those at about every 2 weeks initially, moving on to monthly. So it is worth just bearing in mind that we do still need to check them. You can also, in the higher grade tumours, consider the use of lomustine. So we touched on this with the dog and the fact that in the dog it's every 3 weeks. Well, in the cat, lomustine is given every 4 to 6 weeks, so it's a much more extended interval. The one proviso I lay on this is that with lomustine, because you're giving it orally, you do need to be able to absorb it. So I have a little niggle in my head when I give lomustine to a GI lymphoma in the cat that it might not be absorbed that effectively. And that is my only slight concern there. So in an ideal world, yep, we would go with a CHOP and we would stagger it at the start to prevent GI breakdown, but we're not in an ideal situation right now. And cats do need more manhandling. There's no doubt about it. You're going to be much closer to the person handling the cat than you are with a dog, just because of the physical size of the cat and the fact that they have kind of sharp bitey bits, and therefore you have to be a little bit more on top of them. So you need to weigh up whether this is feasible, and you need to weigh up whether it's feasible for the cat. And oftentimes when I start having conversations with people who have cats, many of them feel that it is a step too far to do that very intensive handling anyway. So just have that conversation with the owner and see what's actually they want for their cat in terms of regular visits, regular handling, and so forth. So the temperament is really important. This cat in this picture here looks really chilled just now, but won't necessarily be when we start doing things with it. So consider the temperament and the overall welfare of the patient when you're deciding what to do. And discuss that with the owner, and that's really going to help them feel that their decision is not being actually that far compromised by the situation we find ourselves in at the moment with COVID. So what about osteosarcoma in dogs? And this is a really interesting one, because you could easily say, well, a leg amputation, that's a big surgery. Is that something we really want to do? Okay, but remember that the main reason we amputate these legs is for pain relief. Okay, and the alternative to amputation is to use things like zoledronate infusions and aggressive pain relief. Now, zoledronate infusions need to be given over a prolonged period, so you're going to be hospitalizing them for probably a couple of hours by the time you've done some bloods and placed the line and then run the infusion. So you're going to keep the patient in. They don't need that much hands-on work during the infusion because it's it's a relatively safe thing to be giving, but they do need to be in and they do need to be coming in. So it is extra workload for everybody. Pretty much all dogs will have Mets, okay? They will all have Mets. It's whether we can see them or not. If they have gross Mets, then the prognosis is pretty poor. So it's definitely worth, if you take a leg x-ray, because these dogs will often present in quite acute severe lameness or with chronic lameness that's just non-responsive to pain relief. So they will present in a situation where you're probably going to have to x-ray the leg. So when you x-ray the leg, if you get anything that you suspect could be a bone tumour, then just x-ray the chest at the same time. Because if it has got extensive Mets, then that might be enough for the owner to call it at that point. Okay, so really, really, really bear that in mind. On the other hand, if you have got some chest Mets or chest Mets develop later on, you're not going to make a judgment on euthanasia based on the appearance of chest Mets. You're going to make it based on the appearance of the quality of life of the dog. So if you have found some Mets and you decide you still wish to go ahead with the amputation from a pain relieving point of view, then you can then say, okay, I'm not going to continue to keep monitoring the chest Mets because actually that's not going to change what I decide to do. I'm really going to decide what to do based on the pet's welfare. Okay, so it's easy to keep looking and keep trying to get guidance as to whether it needs to go or not, but fundamentally it needs to go when it's ready, and you'll be able to tell that just by looking at it, and you'll probably be able to tell that just by looking at it even down a video conference situation. So once you've done the amputation, you're going to get good pain relief, and you're probably going to get around a 6-month survival even if you don't do anything else. So you've then got the option of chemotherapy, and normally we'd be offering chemotherapy, and that would give us 12 months survival. Okay, it's every 3 weeks, so that might be something you can do, but on the negative side, it's an infusion, so that might be something that you don't want to do, and that is an infusion over 20 minutes, and you really do need, depends on the dog, but you do need 2 people to place the line, you do need 2 people to take the line out, and you're going to need 1 person in close proximity with the dog and possibly a second prepared to come in and help, depending on the dog's kind of behaviour. If the dog is really, really chilled after the first dose, you might get away with less people. But it's something that you need to really think about. Is this actually something we're going to be able to deliver? And if it isn't, well, still chopping that leg off is still going to buy a reasonable amount of time and is going to mean good pain relief. So to my mind, this one should happen. But that is something that you've got to decide based on the patient and how well it's going to tolerate it. Usually these dogs are so lame that you know how well they're going to tolerate amputation because they're already on 3 legs. And so it doesn't matter if they've got arthritis in the other leg because they're already 3-legged dogs. All they have is a very sore, dangly thing that needs to be taken off. So that makes life a little bit easier. So moving on to mammary carcinomas in general, sort of a mammary mass, I suppose, it's important to be aware that in dogs about 50% of mammary masses are malignant, but in cats 80% are malignant. So really we have to probably be more aggressive in the cat with a mammary mass because so many of them are malignant. But it's really important to be aware that whilst you might do an initial lumpectomy, many of these should go on to have mammary strips, and that might not be feasible or possible at this point in time. So taking the mass out is great. Part of the reason we do the mammary strip is to prevent new masses potentially occurring in other parts of the mammary tissue, but also because, as you know, many mammary glands are linked in different ways, so they can be linked up and down the chain, and there's also some suggestion they can be linked across the chains. So this case, I think it is worth probably FNAing any mammary mass and saying, okay, with a dog we've got a 50-50 call whether it's malignant or not, so that's a pretty good call. In the cat, we can FNA it, but we know in all likelihood they're much more likely to be malignant, so you might say, okay, I'm just going to do the surgery. Personally, I think an FNA is a quick and easy procedure. You don't need the owner present. You need often minimal restraint for dogs, maybe a little bit more restraint for the cat, but it's quick. You're talking a 2-minute job at most, and that's the whole job, and for that, you're literally in close proximity with a person restraining the dog, which will hopefully be a member of staff, not the owner, so that you're sure that they're taking precautions about coronavirus. And then do you need to do that straight away? No, probably not. You can probably get away with a little bit of a delay, maybe a 2 to 3 week delay, but not much longer than that. So now we're going to move on to urothelial carcinoma in the dog, and this was previously known as transitional cell carcinoma. And these will usually present kind of within the emergency criteria, so they'll be hematuric, they may be obstructed, unable to urinate at all, or certainly will be straining to urinate. And this is because most of these occur at the bladder neck region, so you can get quite quick obstructions just because of the location as much as anything else. And that also makes surgical treatment a challenge for most of the dogs. The cats with the transitional cell carcinomas in the bladder tend to occur at the more cranial pole, so they tend to not present with the same kind of symptoms. They'll have hematuria, but not necessarily this kind of straining and obstruction side of things. We all know that these would usually be managed initially with non-steroidals, and that's going to be your place to go if your patient is a newly diagnosed patient. So that's a relatively straightforward thing to do, unless they're obstructing, in which case we have to probably be a little bit more aggressive. And that non-steroidals alone can give them about 6.5 months, so that gives you plenty of time to rethink once hopefully the lockdown has finished. However, the challenge comes if we perhaps had a patient who's already being managed on non-steroidals or who doesn't respond in that first couple of weeks to them, then we may need to be thinking about using chemotherapy. And this can either involve an every 3-week treatment with mitoxantrone, which has to be given over 20 minutes, or an every 2-week treatment with vinblastine, which is a bolus. So then it's kind of about weighing up what's going to be the impact of those two. They're both reasonably well tolerated in terms of side effects and neutropenic episodes. So are you better having a less frequent visit but having to have a 20-minute closer contact with another individual within the practice where you work? Or are you better having an every 2-week visit, okay, with a bolus? So it's given and it's immediately taken out. And there's no straight answer to that. It may be that your practice is not prepared to do chemotherapy at all, in which case that's not an option, but you can weigh up those two options for you. That might depend a little bit on the temperament of the patient, because again, like we talked about previously, if you've got a very chilled dog who'll just sit for its infusion, then it doesn't really alter the amount of exposure. You're going to need to have 2 people close together for the bloods, and then 2 people close together for the placement of the line, and 2 people close together for the removal of the line. So I guess whether you feel the infusion is possible or not might depend on the patient's temperament. If they're happy to just lie still and don't need a second person to actually be physically manhandling them, then they could be 2 meters away just keeping an eye if there's a problem. So yeah, I guess it's kind of temperament related more than anything on that, and whether you're prepared to do chemo. But obviously starting NSAIDs if at all possible. Some dogs won't tolerate it, in which case it's not an option, but that would probably be your best way forward. Anal sac adenocarcinomas in the dog, they're really actually quite common, and the sort of oncological recommendation is that any dog over 8 years old that's coming in for a routine check, so a vaccine check, etc., should have its anal sacs examined. But in the current climate, obviously those routine checks aren't going to be happening, so they might present as looking at their bottom or scooting along the ground. So you'll remember from the BVA guidelines that scooting was considered something we could handle remotely. So just bear in mind, if the dog is older, so over 8 years old, or in a large breed that's a bit younger, we might need to consider an anal sac tumour. They can also present with hypercalcemia, and in that situation they maybe have excessive thirst and urination. So it's really important when you do that initial telemedicine consultation that you do ask a full history and get everything covered. So if we just do surgery, we can achieve around 12 months. So chopping that out, okay, will buy us a significant period of time. 50 to 80% will get metastases to the medial iliac lymph nodes, and occasionally these patients will present with severe dysesthesia because of really big nodes, and actually the anal sac tumour will be minuscule, and you think that can't possibly be a tumour, and then you see these massive nodes, and that explains it. Now, you can take the nodes out to achieve more remission, but that is obviously more invasive surgery in terms of you going into the abdomen. Sometimes, depending on where the nodes are, it might involve even potentially splitting the pelvis. So that's kind of big surgery. But the removal of the anal sac in itself, particularly if it's the major site of the problem, may be worth removing anyway to manage the dysgeusia situation. We can go on to manage METs with Palladia in the future. Palladia does require regular visits still. It still requires bloods and urine every 2 weeks initially. So you go kind of 2 weeks, 4 weeks, and then you jump to 8 weeks and 12 weeks. So you have a couple of visits 2 weeks apart, and then you have every 4 weeks. But that is something you can bring in at any point. So if you do the surgery to remove the anal sac, and at the moment there's no evidence of METs, you can wait and then recheck for METs again. Probably 3 months would be absolutely acceptable there. And then if you've then got METs, you could think about adding the Palladia in. So you don't need to add the Palladia in automatically. If you've already got METs and you've already got an anal sac tumour and you decide you don't want to do surgery, you could go straight to the Palladia. So this one, it's a kind of, its prevention is better than waiting, because if you wait, these things can get really, really big, and then they are really difficult to manage with the potential for incontinence. Incidentally, one of the things that's really important here is that some of the papers on the risk of surgical incontinence post-anal sac removals for anal sac adenocarcinomas is probably overestimated. I think certainly speaking to specialist surgeons, they feel that the incidence of incontinence is actually much, much lower than many of the original papers reported. So it's definitely worth dealing with it quickly. If you need to delay a week or two, fair enough, but bear in mind that these dogs can actually be really uncomfortable. If they're showing signs of licking and scooting, then they're pretty uncomfortable in that region. Oral melanoma, a really challenging one. It's difficult to look at a tumour and say categorically it's a melanoma. It's not a melanoma. Okay, this one you can pretty much guess. It's got quite a lot of darkness to it, although the dog is a dark breed dog and you can see the gums are automatically dark. So, but you can get amelanotic melanomas, which can just look like normal pink gum and really are not going to give you anything by looking at it. FNAs, if they've got the granules, you can see on the picture there, if you've got granules, it can be quite quick to tell. So an FNA in this situation may be a good option. The bummer about it is obviously they're in the mouth, so FNAing in the mouth is not something you can really do conscious, so that does make it a little bit more challenging. The reality is that if left untreated, these dogs are only going to get a couple of months, and even with surgery alone, it's not going to be a monstrous survival time, and that's assuming you're going to be able to achieve margins. And a very high proportion of them will have METs. So these are not good, but they also are potentially quite high welfare issues because they'll bite down on them, they'll bleed, they can be quite disturbing for the owners to see, they can cause quite bad halitosis and get infected. So this is really a difficult one in terms of they can be quite a high welfare problem, but also we need to be really aggressive if we're going to do stuff with them. On the plus side, non-steroidals have been shown to be a useful adjunct. It's pretty anecdotal at the moment, but there are lots of people out there using non-steroidals, particularly meloxicam. The work that I did when I was at Glasgow showed that meloxicam had a particularly positive effect. So personally, I go melanoma equals meloxicam, and I would definitely have that put in, because you've not really got anything to lose. Unless the dog can't tolerate it, it's really a good option for it. It's also really important to have a good chat with the owners at this point, particularly in our current situation, because there is a limit to what we can do right now, and these patients don't have a great prognosis. Okay, so I have had patients who've had kind of partial resections and then have gone meloxicam and done reasonably well for a reasonable period of time. I'm talking a matter of months, maybe 6 months. But we need to make people understand that in all likelihood this patient will die from melanoma, and it's a question then of how we move forward from here, given the situation that we're in and given that we don't want our owners to be stressing and worried about it. So have that harsh conversation. You can manage secondary infections, you can use meloxicam, and then you can see what else is feasible for you within your practice. I have used Palladia for these patients in the past, so that's an option maybe for the future, depending on what your practice is prepared to do by way of bloods and so forth for these patients. At least Palladia's tablet's given at home, so it doesn't involve you to administer it, but equally it does involve regular monitoring. So moving on to rectal polyps or carcinomas. Now these will obviously present as hematochezia tenesmus, so they meet the criteria of being an urgent, needs physical examination. Now you should be able to feel many of these per rectum, so make sure that you are doing a rectal examination in any dog that presents, even if it sounds like a colitis type problem, particularly if it's a colitis type problem that's not resolved with sort of standard colitis type treatment. I do think that dogs that have had colitis may be more prone to these as well. I think the inflammation that colitis is causing in the intestine may predispose to polyp or carcinoma formation. We can treat these with non-steroidals, and there is studies that show that using suppositories where they're stuck up the bottom can work quite well. You can get suppositories made up by someone like ChemoPet, who, as far as I know, are still trying to offer as close to normal service as possible. If you can't get suppositories, or you would rather give oral and they tolerate oral non-steroidals, then that should also have some degree of effect on these. And the main thing that does is reduce the clinical signs and really improves the quality of life. So that's a really good first step. For some, you may actually get complete remission. They may actually shrink down and disappear completely. And even if the polyp is benign, those non-steroidals will also limit malignant transformations. So whilst hoiking these out and chopping these out, if at all possible, would be great. We don't necessarily need to do that, and we certainly don't need to do that in the first instance in the current situation we find ourselves in. Now, nasal tumours are a bit of another story altogether, unfortunately. These ones tend to be associated with an epistaxis or a nasal discharge. Sometimes dogs might sneeze a lot or make a lot of nasal noise. Unfortunately, the best treatment is radiotherapy here, and that's not really going to be possible at the moment. So we need to consider the fact that is not going to fly right now. Okay, and that does leave us with a big gap, a really big gap, because nasal tumours really need radiotherapy. However, before we did radiotherapy, we did use a combination of carboplatin chemotherapy and non-steroidals for carcinomas. And I have had this case here, which I'm showing you in these images, which was awesome. I really did not expect that. And the dog did super, super, super well. It came back. You know, it came back, it always comes back. But the reality is, this is unusual. It's very unusual to see this sort of improvement with chemotherapy and non-steroidals alone. So even if we do radiotherapy, even if we could do radiotherapy at the moment, we're not looking at a massive survival time. So could we just do non-steroidals as a palliative measure? Yes, and those are probably better than, say, using steroids in this situation, but we need to just be aware that this is not ideal, and we need to be advising the owners. If we go on non-steroidals and then for some reason radiotherapy miraculously becomes available, then just liaise directly with your centre, because non-steroidals can enhance the side effects of radiotherapy, so they may want them to come off a little bit earlier. So we come back to what constitutes an emergency and the guidelines that are currently in place for remote consultation versus physical examination. And I felt that from my point of view, I wanted to come up with my guidelines to help support you as what constitutes essential. So here are my suggested guidelines. I think that in any animal over 8 years old, you need to consider neoplasia as a differential when you're doing a telemedicine consult. And you just need to take on board the impact that diagnosis may have on the clients and may have on your approach to this patient. So just be aware of that and keep that in mind at all times. I think any lumps, including any intra-abdominal lumps, need to be seen within 2 weeks of presentation, unless they're really chronically present. I mean, if it's been there for 6 months, it's not changed at all, fair enough. But realistically, we're probably going to need to do something within 2 weeks. So it's a question of looking at the situation we find ourselves in with not knowing how long this lockdown is going to continue and deciding, do we see it now, or do we delay a week, or do we delay 2 weeks? But really, I don't think we should be pushing on more than 2 weeks, unless, remember that tiny little skin lump, that one you might say, okay, I want weekly updates. I want to have a photograph with a ruler on it, and I'll just keep weekly updates. But if an opportunity comes along to take that out, okay? So it's just a question of kind of really applying a lot of common sense, but being aware that if you miss something that's going to progress rapidly, you're going to feel bad about it, and your client's not going to feel great about it either. Personally, I think anal sac problems need perhaps a little bit more aggressive attendance, because I think it's, it's really tough to manage those without physically seeing the animal. I mean, even an impacted anal gland, you're not going to talk the owner through squeezing anal glands, I think. You're going to do it yourself. So I think these ones probably do need to be seen. I think any patient with anorexia, vomiting or diarrhea, particularly if there's weight loss, really needs to be seen. I think, you can have the one day where your dog's eaten something and then it's vomited up, and that's, that's kind of acceptable, but much more than that, I do worry. I've put together pallor, lethargy and collapse because I think that actually pallor as a differential is a relatively rare thing for an owner to present with. They're much more likely to present with lethargy and collapse, and I think these patients do need to be seen. Obviously you can take that history remotely, but they do need to be seen. I think acute lameness or progressive severe lameness, both of these warrant being seen. You could have osteosarcoma that can walk and then progressively can't walk until it can barely weight bear, and that needs to be seen at that point because that is in a lot of pain. The reason why it's not weight bearing is because it's painful. Coughs and dyspnea, they're a no-brainer. They were both there on the list before, and hematuria and dysuria, and dyskesia and hematochesia, and also the polyuria, polydipsia, particularly without polyphagia for the oncological patients, because obviously your hypercalcemics are most likely to present with polyuria and polydipsia, but not have the polyphagia that you might associate with a Cushing's disease. Cushing's disease, you have to say, is that an emergency? No, it's probably not an emergency, but you don't want to leave it untreated for a prolonged period of time, because apart from anything else, it's going to take you a wee while to investigate it. So my philosophy of cancer treatment is embodied in this slide. It's a journey. Cancer treatment is a journey. We all know what the end point's going to look like, and you can see the ruined farmhouse in the distance. That's where we're all going to end up. We're all going to end up as a ruin. It's all going to end badly eventually. But we have a journey that we're on, and we want to make that path as pleasant and straightforward as we can for our clients. And that is always be my motivation for what I do with my patients. Let's make the path as easy and as lovely as it possibly can be, even knowing that the end point is pretty awful. However, the reality now is not necessarily that we have this clear, pleasant path. We don't know what's going on right now. It's a bit like looking out this window covered in rain. We can't really see what's going to happen. And so the journey can seem a bit bleak for clients right now, and for us as vets. We don't really know what situation we're going to find ourselves in next week, never mind next month, never mind next year. We don't know the outcome, and that is really hard for everybody. Okay, so whilst we want to offer this beautiful view, we can't. We don't know what it's looking like. So please reach out for help. Help us to help you. We will try and advise you on the best possible options. VVS are offering advice calls to enable you to do that, to reach out a little bit more, get that support for you, and hopefully through this talk you've realized that we are very reachable and very approachable. The most important thing is that we are being honest and open with ourselves, with each other, and with our owners. Please reach out if you've got any questions. Please contact VVS and I'd be more than happy to answer them. And I look forward to hopefully speaking to many of you in the days to come and helping you through these difficult times.